So I would like to call upon the chairpersons of the session. Dr. Mohammad Siddiq, he is the current chairman of the Indonesian Ophthalmological Association and faculty staff at the Department of Ophthalmology, University of Indonesia. And of course, Dr. Grover. Dr. Grover doesn't need any introduction here. So please. I would also like to call upon Dr. Usha, the co-chairperson of the session. Again, Dr. Usha does not need any of the introduction here in this forum. Both Dr. Grover and Dr. Usha has been the senior most member of the Oculoplasty fraternity in India and has the legacy of teaching many of us here. So we'll begin the session, the orbit session, with the first talk on orbital infection, and I would like to invite Dr. Anirban Bhaduri for his talk. Dr. Bhaduri is a dear friend. He heads the, from very own Kolkata here, and he heads the Department of Orbit, Oculoplasty, and Ocular Oncology at Sushruth Eye Care Foundation and Research Center. Over to you, Dr. Anirban.
Thank you, Seema. Thank you, Feroz, and the scientific committee for having invited us here. I'll start. It's a tall order. We thought it was 10 minutes, and suddenly I'm gasping for breath. I'll be speaking about orbital infections and infestations. So to start with, these are inflammations caused by pathogenic organisms. They might be microbial, or they may actually be metazoa. Okay, the other thing is that these infections are potentially vision-threatening, and some of them can also be life-threatening. But also remember that there will be other inflammatory conditions which can mimic an infection. And last but not the least, you have the elephant in the room, that is the masquerades. So quickly moving on to orbital cellulitis, these are usually acute infections caused by bacteria, and they often come from neighboring structures. So the sinus being the most important, 90% of orbital cellulitis is actually from the paranasal sinuses, usually the ethmoid, followed by the frontal, maxillary being less common. It could also happen from a periodontal infection. Penetrating injuries are one possible cause. Of course, our dear lacrimal sac being another source. And then you might have distant spread of infection through the hematogenous route. Okay. The other thing is that the infections are more common in young children and then again in the elderly. And there is a difference in the microbiology spectrum as well. So children less than 9 years usually have a single organism infection, while older children and adults can have a mixed infection. Okay, how do you work these patients up? So the history is important, which would tell you how this disease originated, what is the duration. Vision being extremely important here because it's a potentially vision-threatening condition. So look for visual acuity repeatedly, color vision examination, as well as look for RAPD. Check for eye movements. Ask the patient whether the patient can experience diplopia, and of course measure the proptosis, because that would help you to gauge whether the patient is improving with treatment. Among the workups, you would do the blood counts, swabs from the nasal cavity, as well as blood culture. Urine culture if you cannot find a local source of infection. And of course, a CT scan, very important to localize the infection, as also to rule out any sinus involvement. And of course, you can do CRP and procalcitonin, which would also be markers for macrobiological activity. Okay, so with the scans, you have a fairly good idea about where lies your infection. And Chandler very nicely did this classification way back in the 1970s. Preseptal, of course, is not a part of the orbital cellulitis spectrum, but it's important to know. And the worst condition, of course, being the cavernous sinus thrombosis, which is a life-threatening condition. If you look at orbital cellulitis, what distinguishes it from this situation where this child has a preseptal cellulitis is the proptosis, the movement restriction. And of course, again, attention to the pupil, attention to vision. And these patients also have a lot of chemosis. And always examine the tenseness of the lid. Can you open the lid freely, or is it taking an effort? And that is, again, something that you can monitor. Treatment is empirical, intravenous, broad-spectrum antibiotics, systemic analgesics to reduce the pain and the inflammation. And then, would you give steroids? So generally what we do is, after 24 to 48 hours, if we find a response to the antibiotics, is when we start steroids to protect the optic nerve, protect the vision. So this is a child with classical orbital cellulitis, and this is post-treatment. let's look at this situation. So this patient is a diabetic, presents with acute inflammation involving the orbit and has a lacrimal abscess. But you look at the scan, so this shows the inflammation arising from the sac. You have the fat stranding, which is typical of orbital cellulitis. You also have a subperiosteal abscess here, but very important, look at the straightening of the optic nerve and the tenting of the globe. Now this is an ominous sign for vision loss. Again, treatment would be the same as for the previous situation, but here you would also do surgical drainage. Another patient who presents like this with an abscess which is extending into the subdural space. Again, the same principles, drainage as well as systemic antibiotics. Another patient with an orbital abscess. Now you could either do an open drainage under anesthesia, or what we learned from our experience with lacrimal abscesses, you can go in with a white bore needle and aspirate the pus from the abscess. And of course, again, systemic antibiotics and steroids at the appropriate time. Orbital tuberculosis is rare. This is just one patient where I had the experience of, we had actually diagnosed this as a possible tumor because there were no signs of inflammation. And there was a lot of bony abnormalities. You can see all these cavities that have happened. And then, of course, biopsy showed caseation. And this patient was treated for tuberculosis. Shifting gears to fungal infections. How much time do I have? 2 minutes. Okay. So we've all gone through this in the last few years. Mucormycosis. Dr. Honavar came up with this very elegant staging system. I'll just skip this fast. And the salient features, you have features of orbital cellulitis, but look for CRAO, look for any hypotony, which would tell you that there is an ophthalmic artery occlusion. Look for Eschars. So look at the nasal cavity, look at the palate. Does the patient have any stuffiness, pain along the face? Is there any bloody discharge from the nose? And in CNS extension, you could have facial palsy, patient can develop a paralysis, and these carry a very high mortality. Treatment is, of course, with intravenous amphotericin B. You have to control the diabetes, which is the underlying cause. Surgical debridement of the sinuses, debridement of the orbit, or even a exentration of the orbit. And again, the learning from COVID was that you can save certain eyes with transcutaneous injections of amphotericin B into the orbit. Okay, this is the other one, which is not fulminant, but this again can present with, this again has an underlying immunocompromised situation, which is where patients can develop an invasive disease. And this again is treated with intravenous amphotericin B as a first line of treatment, or if the patient cannot tolerate, with voriconazole, and then you can shift to oral voriconazole at a later stage. Now, this particular entity presents as an NSOID, so it is important to do a biopsy. Just as for a mucor, you have to clinically show that there is a mucor infection. Similarly here, you have to do a biopsy to establish that it's a fungal infection and then treat it accordingly. The last, we still have time. So 3 parasitic infestations that we're going to talk about. Orbital myocystic cirrhosis typically presents with a myositis-like feature, so the eye does not move in the direction of the muscle involved. You do an ultrasound, you can show a cavity along with a scolex, or a CT scan could show the same. Some of these patients, if it's involving the apex, can have vision loss. And it's important to treat them with both systemic albendazole as well as steroid therapy to reduce the inflammation that comes once the parasite is in its dying stage. Hydatid cysts are rare infections. You have this situation where you have a multilocular cyst with septi. This is a typical hydatid cyst, and you need to remove the endocyst. These patients can also be treated with oral albendazole over a longer period of time. So this is the last. We had, shall I stop? So this is something that we may not be very familiar with as ophthalmologists, but veterinary surgeons are more familiar with. And here again, you need to do an extensive debridement and then treat the wound accordingly. Thank you. We'll stop here.
Thank you, Dr. Anirban. I think it's a very huge topic, infection, and it's difficult to cover in a short time, but I'm sure there will be questions, and possibly we can take them towards the end.
I think one of the major aspects has been myosisticercosis. Fortunately, it has come down now. Otherwise, at one stage, a decade ago, it was one of the commonest causes for presentation of orbital disease, I mean proptosis or motility restrictions or something. So the change in scenario points to better hygiene probably.
Shima,
And
I have a
food
question
hygiene.
to Dr. Bhaduri and all the panelists also. In case of orbital cellulitis, it is recommended that you can start the steroid, systemic steroid. So what is your takeaway?
Okay, so systemic steroids is not something that you're going to give right at the beginning. Systemic steroids is controversial. I agree. So what we do is we start the patient on intravenous antibiotics and wait for a response. The clinical response would be reduction in pain, reduction in the swelling, your ability to lift up the lid, any improvement in movements, and of course reduction of proptosis. You look for clinical signs of improvement in the first 24 hours. If you don't, you probably have to change your antibiotic, right? And if you do, then that is when we start intravenous steroids. Give it over a short period of time to rapidly control the inflammation.
So when it is not improving at all, within 48 hours, it is not improving, the patient vision is deteriorating, the RAPD is deteriorating, then what you are going to do?
What am I going to do? I'm going to refer the patient to you.
so you have to look for the
This is
cause.
when you need to change your antibiotic. Okay. So always remember with orbital cellulitis, you are treating a presumptive.
Our ENT, like one of the cases you showed is allergic fungal sinusitis.
Yeah.
Our ENT friends, they said that you start the steroid, IV steroid, and it worked wonderful. Because steroid works in two ways. One is that it reduces the inflammatory edema of the mucosa of the sinuses, especially when the sinusitis is the main thing. It reduces the sinus, it improves the drainage of the sinus. That is they are saying.
Ma'am, I don't agree with this. I'll tell you what, in this situation, what you would probably do is, your ENT specialist would debride the sinuses. Okay, do a, what do we call it? Clean up the sinuses, basically, improve the drainage of the sinuses, remove the pus from that direction. You also get a microbiological diagnosis. And then, of course, you change it.
Start the oral steroid first, then
Okay,
you do the
no,
procedure.
I would not agree with that.
They have
Dr.
done it.
Usha,
and
Usha wanted to say something, please.
No, can I say something? I think we'll have to have a judicious approach to this. One, as Anirban had mentioned, that we start off with antibiotics. Probably on day 2 when things are looking good, we would supplement it with injections, IV steroids. And again, that has to be judiciously used based on the systemic conditions as well. So there's no harm, and in certain cases, you probably would simultaneously start under cover of antibiotics.
Yes, there are studies which have shown that the resolution of the delayed signs, like, I mean, the motility, the proptosis becomes much faster with steroids, but the use has to be judicious, making sure that the antibiotics are having an effect. If you have an organism which is not sensitive, or probably you not made the correct diagnosis of bacterial or fungal or whatever, then the use of steroids could be harmful. So take it as a double-edged sword.
I think one take-home message, like in your presentation, would be, please do not start the antibiotics in cases of orbital abscess. A few of the cases where you showed, there was a subperiosteal abscess. Sometimes we tend to give the antibiotics and then try to drain the abscess. You will not be able to succeed because it will form an antibioma. So it's best to drain the abscess. Whenever you see a case of abscess, drain the abscess first, start the antibiotics, and then supplement with steroids would be the order of
So would you change that approach for whether, depending on the age of the child?
So in children, there are studies which show that systemic drugs themselves can take care of periorbital
Up to the age of
Up to the age of 9 years.
9 in
years. So
several
that is the
studies.
cutoff.
So maybe the approach
So if
can
we
be
see it's a
more,
good response, we would not
yeah.
need to do a drainage.
maybe you need to approach earlier in children over 9 years for drainage. I think we should move on to.
Thank you very much.
So we will now move on to the inflammation after the infection, which is again one of the major chunk of the orbital diseases that we see. And we all are aware about the cardinal signs when we label any pathology as inflammation. Hot, red, swollen, painful, and loss of function, and we have all read it in pathology. We just spoke about infections, and this is a young guy who has a hot, red, painful, swollen orbit with loss of ocular movements, and we do see a mass lesion in the orbit. Now, it fits into the criteria of the orbital inflammation, but he does not respond to the conventional treatment. So what we do next is we do a biopsy and we find fungal granuloma. We have been talking about the fungal infection. So this is a fungal infection of the orbit which presents as an inflammatory pathology. Similar pathology is another young lady, comes with some signs of inflammation of the orbit. There is an inferior orbital mass. Biopsy shows some sort of caseating granuloma, and some other workup for the tuberculosis also turns to be positive. Started on ATT, does not respond, worsens, the orbital mass has increased in size. In the meantime, the eye becomes painful. There is a thinning and perforation of the cornea, eventually leading to an enucleation, and here we see the small vessel vasculitis. Cianca is raised, so we get a specific diagnosis of Wegener granulomatosis. So what we are trying to look at here is this is the inflammation. One had a specific cause like a fungal infection or a foreign body granuloma maybe, which presented with signs of inflammation. And the second one was an inflammation with a specific histopathological features like what we see in Wegener's. And the third category which we usually deal with, the more major chunk, is what we call as non-specific orbital inflammation after everything else is ruled out on biopsy. Now, what we have to be careful is that non-specific inflammation is a diagnosis of exclusion once we have ruled out the specific causes based on clinical features as well as on histopathology. Now, it's not a single disease entity, it's a combination of various disease presentation, but the unifying feature is that they have a very abrupt onset of inflammation, extremely painful, and the sensitivity to the steroid is something which sort of is a common feature in many of these patients. And imaging will show some either mass lesion of the orbit, and there will be enhancement of the contrast because of the edema in the orbit. But so saying that atypical presentations are possible. According to the patterns of presentation, depending on which structure in the orbit is involved, it could be myositis, dacryoadenitis, and many other involvement. Now, if you see this young girl, she comes with some amount of conjunctival congestion. There was pain on movement of the eyeball. Ocular movements are restricted, as we can see in the right eye, the elevation is restricted, but there is no edema or swelling in the orbit. And now, we are not going to label this as orbital inflammation based on the classical signs, but what we see on CT is a diffuse thickening of the inferior rectus muscle with fuzzy margins, and this thickening is involving the tendon of the muscle. So it was a clinical diagnosis of myositis. We started her on steroid, extremely good response after a few cycles, which again confirms the diagnosis. So the first pattern of inflammation, which is pretty common, is a myositic pattern, which could be acute and subacute or chronic. Like this patient had a subacute presentation, could be one muscle, could be multiple muscle enhancement, but the unifying feature is thickening of the muscle, which tends to involve the tendon of the muscle. Sometimes there can be bilateral involvement, and the most common differential for the myositis remains an active thyroid eye disease, because even an active TED will have signs of inflammation with the thickening of the muscle. But what we see in thyroid thickening is that traditionally is the tendon sparing thickening of the extraocular muscle, which helps us in differentiating. In our setup, Dr. Grover was just talking about cystosarcosis. That is probably the most common cause of myositis, presenting as a myositis with inflammation signs, especially in young adults, which needs to be ruled out and picked up on ultrasound or on imaging findings. Rarely some neoplastic infiltration of the extraocular muscles, like in this gentleman it was lymphoma, can also present like a myositis picture with signs of inflammation, but biopsy again confirms the diagnosis. How do you manage a myositis? If it's a unilateral disease, the first episode, usually there's a good prognosis, conservative treatment is enough, either with non-steroidal, anti-inflammatory, depending on the severity, or with steroid. But if it's an atypical presentation with multiple muscle involvement or a recurrent course, it's best to do a biopsy, rule out any systemic involvement, and treat the patients accordingly. Moving on to the second pattern, this is dacryoadenitis. We all know about the S-shaped deformity of the eyelid. Again, there are signs of inflammation here. Prominent lobe of the gland, pouting lacrimal ducts are again features. And we treat this patient based on the functional involvement of the gland, and the Schummer's value is a reflection of the function of the gland. If the Schummer's is affected too much, if there is a severe dry eye, that means the gland has more severe inflammation, and we tend to be more aggressive with the course of the steroid. Again, dacryoadenitis something is not always a non-specific inflammation, like in this young lady. It's like almost like a mass lesion with a swelling and thicken or enlargement of the gland. Biopsy shows this intertubular fibrosis, lot of inflammatory infiltrate, and her IgG4 and IgG ratio is more than 40%. Serum IgG4 was increased, so that gives us a diagnosis of IgG4 related disease, which is more recently we were not aware of this disease in the very near past, but now more and more diseases are falling in this spectrum as we biopsy more and more of them, and we are aware of the findings. And if you see the review of the literature, there are specific criteria to diagnose them. Many of these earlier inflammation, which were labeled as idiopathic or orbital lymphoid reactive hyperplasia, many of them probably was falling into the spectrum of IgG4 disease. Again, it is important to recognize it because these are more recalcitrant to treatment, needs high dose steroids, and sometimes does not resolve completely with steroid and might need some surgical debulking. Just to also not forget about infection, which can sometimes involve the gland. This gentleman, bilateral rectoadenitis presentation, but on biopsy, we picked up caseating necrosis, and there was actually AFB present and confirming a diagnosis of tubercular involvement. So rectoadenitis can, instead of idiopathic, it can also be present in many bacterial, viral, sometimes neoplastic infiltration like leukemia, lymphoma, and other systemic disease can also mimic it, which needs to be ruled out before you label a patient as a idiopathic rectoadenitis. The third pattern is diffuse involvement of the orbit with all signs of inflammation, but extreme response to steroid. This is just after 1 day of IV methylprednisolone, and we can see the inflammation just gone. But again, here we have to rule out other diseases like a keratoconus fistula, which will be more chronic, but can have chronic inflammation of the orbit. Of course, we are aware about the orbital cellulitis. We just saw some of the pictures. Lymphangioma with bleed can sometimes with an acute orbit, which needs to be one of the differential, and infiltrating tumor needs to be ruled out before we label a patient as an idiopathic diffuse orbital inflammation. The other two patterns, the apical NSOID as well as the perineuritic variant, are less common but can present like an optic neuritis. Like in this young girl, there was a diffuse thickening of the optic nerve sheath, fuzzy orbit, signs of inflammation, again, and very good response to steroid. The last spectrum is a gentleman who has all the signs of inflammation, pain, red orbit, swelling, function is affected, but what we see is a lot of bony destruction and a mass lesion formation in the orbit, which is not a very common feature of orbital inflammation. So what we do here, of course, we do a biopsy, and biopsy shows a sclerosing variant of NSOID, which can sometimes present like a mass lesion with bone destruction also. Unifying feature here is desmoplastic reaction on histopathology, extreme fibrosis on histopath, and these are again the variant which are pretty difficult to treat. This was after IVMP. Now, just to conclude, how do you approach an NSOID? If there are typical features, and it's the first episode unilateral disease, we treat with NSAIDs or low-dose steroids. Prognoses are good and recurrence are unlikely. If it's a bilateral recurrent disease or any apical or perineuritic involvement, which are more significant, we tend to give high-dose steroid. Immunosuppressants might need to be added up, and we investigate for systemic disease based on the biopsy finding, and close follow-up is indicated because we know there can be recurrence. And if it's an atypical presentation or if we are suspecting a sclerosing variant, we also need to be maybe a little more aggressive with the surgical debulking also at times. So thank you very much.
Thank you, Dr. Seema. That was an excellent overview. I think it's too vast a subject to be covered in such a short time, but you did a great job. Thank you very much. If there are any questions, probably we'll take it at the end of the session.
We will stick to questions at the end only. May I now request Professor Muhammad Siddiq, a very eminent surgeon from Indonesia. He's the past president of Indonesian Ophthalmological Society and a highly respected figure, highly honored figure in the country and internationally. He's at the Faculty of Medicine, University of Indonesia. A privilege to have him speak to us on thyroid eye disease. What is new to know?
Thank you, Dr. Ashok. Good offer, my Miss colleague from India. First of all, I will thank to the committee who has been inviting me to speak in this very precious moment. It's very honored for me. I want to talk about the thyroid eye disease. I have no financial closure. On this occasion, I want to share my experience about thyroid eye disease. What were the clinical manifestations, how to diagnose, and also how to classify the disease, and also the management of patients with thyroid disease. As we know, thyroid eye disease is autoimmune disorder. Thyroid eye disease are also called as grave ophthalmopathy, followed a biphasic course in which an initial active phase of progression is followed by a subsequent partial regression and a static inactive phase. It most commonly seen in association with Graves' disease and Hashimoto disease, but can also occur in euthyroid states and primary hyperthyroidism. Thyroid eye disease is the most common cause of both unilateral and bilateral axial proptosis or exophthalmos. Thyroid dermatopathy, also called as pretibial mixed edema, a nodular or diffuse thickening of pretibial skin, sometimes progresses to debilitating disease. Mild cases of thyroid eye disease are often misdiagnosed, which prolong the diagnostic and therapeutic process leading to exacerbation of the disease. Upper eyelid, the most common sign of thyroid eye disease is upper eyelid retraction. Upper eyelid retraction itself is produced by levator or molar muscle inflammation and fibrosis, or by levator complex overaction secondary to inferior rectus retraction or pseudolid retraction. Proptosis is caused by expansion of the orbital fat or muscle. Also, the lacrimal gland is frequently involved and enlarged. Sometimes the ocular sign will be involved, such as SLK. SLK is characterized, or superior limbic keratoconjunctivitis, is characterized by upper tarsal conjunctival hyperemia, limbal papillary hypertrophy, punctate epitheliopathy, and filament in the upper cornea. Thyroid function test should be performed for all patients with SLK. There are several classifications used for grading the severity of the disease, such as NOSPEC, CAS, VISA, and AIOC. Some of them could be used to start the management. The classification CAS, or Clinical Activity Score, is usually used to initiate the treatment. AIOC classification is also used to assess the severity of the disease, but this classification grades exclusively for clinical severity and does not provide a means of distinguishing inflammatory progressive from non-inflammatory stationary grave ophthalmopathy. The active phase of the thyroid eye disease occurs when inflammatory clinical characteristics are changing and progressive. The active phase can last up to 24 months, as described by Randall, and is then followed by inactive phase. The active phase itself can be prolonged, or the disease can be reactivated by certain risk factors, including smoking. About 1% of patients experience reactivation after a period of inactivity. There is no signaling of the beginning of the inactive phase, but stability of clinical finding for a period of 6 months may indicate transition of the inactive phase. Computed tomography or magnetic resonance imaging of the orbit is warranted when the cause of ocular manifestation remains uncertain. These imaging studies are useful in distinguishing extraocular muscle enlargement from fat expansion, especially in case of asymmetric proptosis. The rolling orbital tumor and arteriovenous malformation is important. CT and MRI have the advantage of imaging the entire orbit. CT is more sensitive for showing extraocular muscle enlargement. In active disease, the extraocular muscle must appear as hyperintense on T2-weighted MRI. A typical eye feature requiring confirmation of the diagnosis of thyroid eye disease by orbit imaging, such as unilateral disease, unilateral or bilateral disease in patients with no previous evidence of thyroid dysfunction, absence of upper eyelid retraction, divergent strabismus, history of diplopia worsening toward the end of the day. Routine measurement of thyrotropin receptor antibodies is not mandatory, but when such assays are performed, they have 99% sensitivity and specificity for Graves' disease. This protocol for management TED has been compiled by our team in our hospital and has been used to manage our patients with Graves' disease. We classified patients with GO into mild, moderate to severe, and sight-threatening thyroid eye disease. In mild cases, selenium plays a role in the cellular redox maintenance and may reduce reactive oxygen species. There were a significant improvement in both overall ocular improvement and quality of life at 6 months, which continued at 12 months with discontinuation of selenium. No adverse events associated with selenium treatment. On managing patients with thyroid eye disease, we have to strict on these 5 things. That is, refrain from smoking, restore thyroidism, avoid iatrogenic hypothyroidism, refer to endocrinologists for multidiscipline management, and search for dry eye syndrome. In mild GO, in mild thyroid eye disease, we could give local treatments such as artificial tears, ophthalmic gel during the night. Adjunct therapy such as selenium supplementation could be given to reduce severity, reduce progression or slowing progression, and improve quality of life. If quality of life markedly impaired, we could discuss follow immunomodulatory in active thyroid eye disease or rehabilitative surgery in inactive thyroid eye disease. On moderate to severe cases, systemic corticosteroid is mandatory to achieve direct inflammatory effects. In our hospital, patients with moderate to severe thyroid eye disease will be given 500 milligram IV steroid per day for 3 consecutive days, repeated every week for 4 weeks, plus mycophenolate mofetil 720 milligram for 24 weeks. It should be remembered that this treatment will not modify the disease, but can help soft tissue signs. This scheme showed the second-line treatment if steroids show no improvement. Several monoclonal antibodies that has been proved for thyroid eye disease are teprotumumab, rituximab, tocilizumab. This medication was mainly used for second-line treatment because the price is quite high, and I think not all patients can afford this medication. The condition that we have to aware is sight-threatening condition. This condition can be caused by dyssteroid optic neuropathy or severe corneal breakdown due prolonged corneal exposure. Methylprednisolone IV is a mandatory treatment. If dyssteroid optic neuropathy improves after 2 weeks, pulse methylprednisolone should be continued as for moderate to severe active TED. Severe corneal exposure need to medically or progressively more invasive surgery such as orbital decompression. In inactive thyroid eye disease, treatments are mainly for rehabilitation. For example, rehabilitative decompression for corneal exposure or cosmetic condition, prism glasses or strabismus surgeries to reduce stable diplopia or eyelid surgery. This is case number 1. Patient came to our clinic. He is male, 57-year-old with protruding of both eyes since 3 years and was given oral steroid due to orbital myositis in other hospital. He had history of active thyroid eye disease and moderate to severe. On March 2019, he came to our hospital at April 2021. On laboratory examination, the thyrotropin receptor antibody was quite high because of his ptosis. She also just 2 minutes. Sorry. He also performed the EMD examination, and the result is positive. So this patient also have ocular myasthenia gravis. On case number 2 is male, 50-year-old with sight-threatening thyroid eye disease. We could see the condition of the eye, both before and after intravenous steroid and orbital decompression surgery. We could see that there was a significant improvement after we did the IV steroid and orbital decompression. So for take-home message is simple cure of TED clear is unavailable. Current treatment guidelines include regimens of medical and radiation for active severe disease. Timing of initiation of treatment is crucial. Type of treatment should be tailored to the physical and psychological condition of the individual patient. Thank you.
Thank you, Dr. Sidek, for that wonderful perspective and overview. We'll now look forward to the Indian view from a high volume, high quality center in India. And Dr. Surya is eminently qualified to present that perspective as a wonderful, experienced oculoplastic surgeon.
Thank you. It's really nice to be here among experts. Very good idea to have the subspecialty. Also extremely nice to see and happy to see Dr. Leone and his wonderful work. And thank you, Professor Siddiq, to give an overview on how exactly management of thyroid eye disease. I'll try to delve into what is new in thyroid eye disease. And this is my only financial disclosure. Just wanted to say that I'll try to pick up things which are relevant to us. Otherwise, if you start talking about what is new in thyroid eye disease, you could probably start and end with teprotumumab. Essentially, when you are trying to put a patient into a classification system, you say this particular patient and you always kind of know which one. You should be taking the worst eye. But do you take the worst eye, you take the other eye? There are so many confounders. So essentially, what do? We know about several classification systems that exist, but all of them sort of have their own challenges in this one. So essentially, this is what we do. We try to sometimes, if it's a symmetric disease, follow the fellow eye and try to put it onto a classification system that works in sometimes. But a lot of times, actually, the deeper orbit you have access with a form of imaging, which you could possibly use to put a score and then plan a management. Most of the times when you have patients like this, you're definitely looking at decompression to save the eye, and you have quite gratifying results. The other thing that is important is not much is talked about this form of sight-threatening disease, which is corneal breakdown. We know about sight-threatening disease, DON a lot, risk factors and other things. But here, I think if you go back to the older classification system of Werner's, tends to talk a little bit about grading these into where you just have superficial punctate keratopathies, you have an added component of infection, which complicates things, and then you have an impending perforation or already a perforation. Whatever said and done, actually, the ones which are moderate to severe tend to do very well if you have a very expeditious plan, definitely constituting decompression, but more important than that, it is multiple things that come into play. The second point I want to bring in is Rundle's curve. Now, Rundle's curve in thyroid eye disease is like a religious dogma. And actually, we all talk about it. But I just want to bring in one new thing which actually is brought out in this particular recent report from Dr. Cruz. And he actually brings out where exactly did it start out from. And essentially, this was based on a series of articles from 45 to about 50, and several articles came out. But the key thing was there were only 12 patients and 24 eyes that we are talking about. This is a very nice read. I would definitely recommend this. But just to say that very few of those patients, based on the proptosis and others, actually fell into this biphasic course that we follow as a religious dogma. So essentially, whether we should only just keep thinking about this Rundle's curve and manage is a question, but a good read anyway. The third thing I want to bring in is a lot of people now depend upon imaging, MRI. There are several parameters we look at. What I've tried to show with a yellow arrow is a signal intensity ratio, which we tend to follow quite often. But again, a very nice article by Louis Mon talks about not only signal intensity ratio, where you compare the intensity of the extraocular muscle and compare it with one of the, let's say, a temporalis muscle or anything outside the orbit within the same field of view. but essentially also T1 and T2 relaxation times, which are helpful in putting activity, and that's really helpful. Another patient to show the same thing, but how it really helps is in this particular patient who has upper lid retraction. And based on imaging results, we tend to show a thickening in the SRLPS, very good results and gratifying with either a transcutaneous or a transconjunctival injection of triamcinolone in upper lid retraction. 4, well, the combination of steroid and mycophenolate in the 21 guidelines of UGOGO came as a big relief. Essentially because you have your own challenges of treating patients, particularly you are diabetic, and this particular helped. I'm trying to show one particular patient where we treated with mycophenolate and then moved on to doing a surgery. And this particular site was also showed by Professor Siddiq. Essentially, it tells you that you can either look at combining IVMP with mycophenolate, and with the kind of safety margins that mycophenolate has, it definitely comes to our rescue. This is another patient that I wanted to show and came in with decreased vision. We actually did a decompression, followed him up with putting him onto a therapy on mycophenolate for about 5 months, and that's his. Essentially, the other thing is his right eye vision didn't improve completely. And something interesting, this was actually seen in the retina clinic, and they had done both the RNFL and the and essentially what it showed in the right eye was there's a significant degree of thinning already. Now, the key point I want to bring in is there's a lot of literature already about the importance of the ganglion cell layer and the RNFL layer thickness. How exactly does it help? Would we have done anything differently? I don't think so. But the point to note is that this is a particular parameter that is very much in vogue and is being done in thyroid eye disease patients. Our own work has, of course, shown that the diabetes remains a major risk factor, almost as important to us or maybe more compared to smoking, doubles the risk of dysthyroid optic neuropathy, and our own work tends to suggest that you probably have to treat them a little differently. And the key things, there are a lot of things. Obviously, patients with diabetes and thyroid eye disease should be treated in a multidisciplinary clinic. But the key things are you have to probably look at what are the drugs you tend to take for diabetes, metformin preferred, look at the lipid levels, also very closely follow the blood sugar levels. But if you're facing a patient who has multiple risk factors, old age, diabetes, smoking, 2 or more, as we say, then it's better to probably think about surgery first and then put them onto immune modulation for saving the nerve, and particularly in sight-threatening disease. This is one particular patient where we had done early surgery, bilateral endoscopic decompression, and then put him on therapy, and he stabilized. What you're also looking at is trying to keep a more broader posterior orbit and decompression to get that effect, and that's what I'm trying to show on the scans. Last, you're talking about stage versus simultaneous surgery, something that we get stimulated for. We obviously know patients which are very long-drawn rehabilitative surgeries to correct them. And that's what we have always known, orbit, muscle, eyelid. Essentially, now there is a concept that you could have simultaneous surgeries, and this is one particular patient. We are just learning, but essentially, you not only take care of the orbit, but also take care of the muscles, and that's what he is after a sequential decompression, but the muscle surgery is done along with the decompression. Another patient where a customized surgery was done in thyroid eye disease, and that's her after the surgery. And again, another patient who had double vision to begin with, 30 prism diopters, and post-surgery in the right eye, she's single vision in the primary gaze. Teprotumumab, we all know, huge response. It's not available to us, but the most important thing is one of the few which gives a response in proptosis and looks like even beyond active disease. A little bit of a concern both on the hyperglycemia front and the hearing impairment that it causes, but something that we need to look out for. On our front, we can probably just use tocilizumab, which works not as much on the proptosis front, but we use it every often now and whenever we faced with a recalcitrant patient who's not responded to either the combination of IVMP with MMF or is recalcitrant because there is a reactivation disease. This particular one had a thyroid nodule which needed surgery. So that's all I have in what is new in thyroid eye disease. Thank you.
Thank you for highlighting the most important developments. And since we do not have time, we actually have a 72-minute program for a 63-minute session. if you add up. So we'll have to move without any discussion. So Dr. Usha will be speaking on optic nerve fenestration technique and outcome. She's the past president of OPI and a teacher to a whole generation of oculoplastic surgeons and an inspiration to every one of them.
Thank you for those nice words. Thank you very much. I will be talking about optic nerve sheath fenestration. Now, just let's look at what is available for the raised intracranial hypertension. There are CSF diversion procedures, that is the ventriculoperitoneal or the lumboperitoneal shunt, the optic nerve sheath fenestration, transverse venous sinus stenting, the efficacy of which is debatable, and the bariatric surgery for the weight loss. Now, it was D. Wecker who initiated the treatment of papilledema by performing the optic nerve sheath decompression excuse me, using his own peculiar instrument through the conjunctiva without any visualization of the operative field. Now, Hare in 1960, he artificially produced papilledema in an animal model and demonstrated that creating a window in the dura of the optic nerve sheath produces bilateral relief of optic disc edema. This was the background that we have. And the mechanisms of fenestration, the obliteration of the subarachnoid space surrounding the optic nerve by fibroblast proliferation, preventing the CSF pressure transmission distal to the operative site, and creation of a dural fistula which allows the egress of the CSF. So we'll have definitive indications for optic nerve sheath decompression or fenestration, progressive loss of vision, papilledema that's refractory to medical therapy. These are the indications that we have to keep in mind. And the options that we have are a lateral approach or a medial approach. Lateral approach could be a lateral orbitotomy with or without bony flap removal. And a medial approach will be medial transconjunctival or a superior lid crease incision. It's performed under general anesthesia. A high-risk consent has to be obtained, and you have to definitely give a guarded visual prognosis even in a seeing eye. So with this background in mind, let's go through this case history so we'll understand it a little better. A 17-year-old woman with sudden painless loss of vision in both her eyes, restriction of lateral movements of both eyes of 2 days duration, repeated headaches over a year, neck stiffness, pain with a little bit of pain, treated as a case of migraine, which is quite common, and 3 episodes of headache per week. So an MRI was done obviously, and it showed a normal study. On examination, patient was obviously normal otherwise, with a weight of about 79 kgs, which is to be noted, and a blood pressure of 170 over 120. Other systemic examination was normal. So with papilledema both eyes and a typical picture like this as you see, her visual acuity in the right eye was PL plus PR inaccurate, and left eye was hand movements. Pupil was dilated and fixed. And there were movement restriction. Adduction was restricted. The next day, the patient had right lower motor neuron type of 7th nerve paresis, right proximal upper limb paresis, diminished plantar response, and worsening of the neck stiffness and pain. And rest of her profile was normal, except that her CSF opening pressure on lumbar puncture was 12 centimeters of water, and CSF analysis showed an increased protein. With this in mind, the treatment by the neurophysician, that is a neurologist, was IV mannitol, Lasix, Diamox, and steroid injections, antihypertensive medications, and ATT was empirically started. However, the TB PCR seemed to be negative. A visual acuity of right eye hand movements and left eye 624 was obtained. Then a repeat MRI was done, which showed a dural venous sinus thrombosis. Now for this, we went ahead and did an optic nerve sheath fenestration. As shown, you make a conjunctival incision, isolate and disinsert the medial rectus, and you elevate the globe and abduct it. Keep monitoring the pupil. Go along the posterior ciliary artery, and you use your MVR blade or a paracentesis knife. Now, recently I've started using the paracentesis knife as well. Make a nick on the optic nerve sheath carefully, and you can see the gush of CSF, and you can make multiple nicks in order to create a window. You can use a scissors. It's easily said but can never be achieved very easily, so I try to do the multiple nicks and connect them all. You can use a myringotomy scissors. You can borrow it from the ENT friends, but it's not very easy, as I said. And when you make multiple nicks and connect them, you create a window. Once this is done, you can reattach the medial rectus muscle carefully and close the conjunctiva. Now, the vision in the right eye became 624 and the left eye was 6/9 partial, and the restriction was only -1 post-op day 1. Day 2, 618 improved to 618, and the left eye 6/9 partial. There was resolving disc edema both eyes. Right eye showed a pallor, blood pressure came down, and this is the fundus picture. You can also see the thinning of the edema is reduced post-operatively, but you can also see the secondary optic atrophy. So, if you look at the course of events over a period of about 11 months, vision corrected over to 6/9 in the right eye and 6/6 in the left eye, though there was peripheral constriction of fields, but the extraocular movements were full in this particular patient. So the next, I went ahead and explored the other options also. I started doing the skin crease approach, and here again, you can go directly to the optic nerve. So the one point that I'd like everyone to remember is, please do not choose an obese individual for a skin crease approach, because the fat is going to really be in your way and will never let you reach the optic nerve very easily. But in a thin individual, you probably can resort to doing a crease approach. And even as you puncture very minimally, you will start seeing a minimal fluid trickle. Sometimes it may be difficult to approach, but once you make multiple nicks, then you can see the fluid seeping out, and you can use gentle suction, and you will see that it keeps seeping through. So this is a real easy procedure when approached from the lid crease, but care to be taken that you only choose patients who are not very obese. Now again, I'm trying to show another case where we went ahead and did the release of the fluid, and you can see that you can see the opening as well. But that's not adequate, so you need to make multiple nicks and connect them all. So if we keep making the multiple nicks, you'll almost have a very good window made, and you reattach. You can even avoid disinserting the medial rectus muscle. So in conclusion, patients who fail conservative and maximal medical therapy for papilledema and headache require surgical intervention. So optic nerve sheath fenestration for patients with predominantly visual symptoms, they are the good patients for such fenestration treatment. And the shunts for patients with headache. So one strong message is, if there is headache, we can go for shunt, but when there is more of a visual loss, I think we should resort to fenestration. And this message has to be given across to the neurologist, because it's often very late that they refer these patients to us. So in our experience, we took about 102 eyes of 83 patients. 20 patients had bilateral papilledema, and visual improvement was seen in 37% of cases, that is 38 cases. Worsening was seen in 34%, that is 35 cases, and no visual improvement is seen in 28 eyes, which is 28%, which is 29 patients. So there are cases which have improved from no PL to 5/60,
which is again to be kept in mind, it was a recent onset, so it was referred early to us. Cases improved from 5/60 to 6/12, and there were 6 cases which underwent prior VP shunts as well. So the most common indication is IIH, raised ICT of unknown etiology. Most common symptoms are early morning headaches, transient visual obscurations, visual field loss, double vision, sixth nerve, paresis. So good prognosis is seen in patients with good initial presenting visual acuity, shorter time for intervention. Unilateral surgery had better prognosis for both eyes than did bilateral surgery, and acute visual loss likely to improve than chronic visual loss with poor acuity and irreversible optic nerve damage. Thank you very much.
Thank you, Dr. Usha, for that wonderful talk, the beautiful videos, and for sharing your experience. This is definitely not a very common entity and a difficult surgery to tackle. And again, for the interest of time, there will be definitely some questions, but we can take those up later. So we now move on to the talk on orbital tumors and the current management by Dr. Santosh. He doesn't need any introduction in this forum. So over to you, Dr. Santosh.
Thank you, Seema. I'll be speaking about protocol for the management of orbital tumors the next 10 or 12 minutes. Orbit is a Pandora's box. There's a lot of evil in it, which is actually true because 50% of orbital tumors that you see happen to be malignant tumors, where there is concern about life salvage as well, apart from eye and vision salvage. So your protocols have to be very well defined. When you're dealing with a benign tumor, obviously you would want to remove the tumor completely. When it's a malignant tumor, sometimes you have to use multiple other modalities to treat. The goal always remains the same, irrespective of which cancer it is. First goal or the primary goal is life salvage, secondary goal is eye salvage, and tertiary goal is vision salvage, and you can't reverse these. Whenever you have a patient with orbital tumor sitting in front of you, you have to ask several questions and answer these yourself. What is it likely to be? Where is it located? Is it intraconal, extraconal? Does it have intracranial extension as well? What are its relationships? Is it related to any of the critical structures in the orbit which are functionally important? Is it operable at all or not? What is the approach then? Would it be transconjunctival? Would I cut the bone? Or can I not operate it? Would I need a neurosurgeon to help me? And what do you expect out of it? Do you want to completely remove the tumor? Would you have any complications? Would you explain the patient there's a higher chance of vision loss in a given situation? All these has to be assessed by a good clinical evaluation, followed by appropriate radiology, which could be CT scan, MRI, or both, and sometimes even a PET CT scan. Now, based on that, you arrive at a differential diagnosis, and it is good if you know what is important or what is the most important tumor in your region. This is some Indian data. And also based on whether it's a child, axial proptosis, abaxial proptosis, subacute, or chronic onset, you will be able to further narrow down the differential diagnosis, which is extremely important for you to plan the treatment. And also whether it's a well-circumscribed spheroid tumor, well-circumscribed oblong tumor. Based on that, you will narrow down your differential diagnosis further. For example, a tumor of this sort would be arising from supraorbital nerve, and that is the nerve, and that's neurolemoma. You already know the diagnosis. So you have to explain to the patient there will be consequent loss of sensation in the forehead and scalp if you were to operate this patient. Adenoid cystic carcinoma, obviously, if you know the diagnosis already, you would do multimodal treatment. Triradiate lesions have very specific differential diagnosis. Now, based on this, you arrive at a logical stepwise approach. This would mean that at the end of your clinico-radiological summation of diagnosis, for a set of patients, you would say definite no to surgery. For a set of patients, you would say a definite yes to surgery, and there are patients who lie in the gray zone where you may do surgery or may not do surgery. This is one such situation where there is a metastatic Wilms tumor already where you will definitely not want to do surgery. How do I say that? Because it's a bilateral proptosis in a child with a triradiate lesion, temporal fossa fullness, it has to be metastatic Wilms tumor. There is no other differential diagnosis. In a similar situation where there is periocular hemorrhage or raccoon eye sign, it has to be metastatic neuroblastoma. There is no differential diagnosis. Here you don't need to do surgery. You simply refer the child to a pediatric oncologist. If a child were to have acute proptosis, left eye acute proptosis, subconjunctival hemorrhage, and on seeing the fundus, you have rot spots, this has to be granulocytic sarcoma. You simply do a peripheral blood smear. Don't subject this child to the risk of anesthesia and a biopsy. Peripheral blood smear confirms the diagnosis, and there the child goes to a hemato-oncologist. In a situation of multiple myeloma, this patient had a history of prior multiple myeloma. Where there's a triradiate lesion, you're sure it is plasmacytoma clinically because it's a triradiate lesion. And all that you do here is a FNAC, and that will confirm the diagnosis. You don't have to open up for an incisional biopsy. Now, there are non-surgical approaches as well. This was an airline pilot with evidently no proptosis. He looks very normal, but he has this tumor which is impinging on the superior orbital fissure and the optic nerve with visual field loss, which has failed him in his medical exam, and he can't fly anymore. And that's the only occupation that he has. He doesn't know any other job. So you have to save his vision. And if you were to meddle in this area too much, although it is cavernous hemangioma, he may have a risk of vision loss or visual field loss, which may exacerbate further, or even diplopia. In such situation, we would choose a conservative approach, which is stereotactic radiation. You can see impressive reduction in the tumor volume and consequent reversal of visual field defect. We give a slightly higher radiation here, but we have learned that even a lower dose radiation works. 2000 centigrade was used in this published case, where you see this tumor, which is very much apical, has become much smaller with complete reversal of the visual field defect. So the current concept is, if a tumor is in the shape of a pear, if it is kind of impinging on the superior orbital fissure and the orbital apex, you may not want to surgically operate and consider other alternative modalities. Now, some patients we deal with only injections. There's a young girl who only wanted cosmesis. She's not bothered about anything else. She has recurrent subconjunctival and periocular hemorrhage. She has a lymphangioma, which you may want to debulk, but look at its critical location. Around the optic nerve, lacrimal gland, all the muscles are involved. You wouldn't even want to go by the conservative supratemporal approach here. You would rather give an injection, which could be either picibanil or bleomycin. Here we choose picibanil mainly because it's an intraconal lesion all around the optic nerve, and we know picibanil is safe for the optic nerve compared to bleomycin, which can have visual reduction. So this girl did very well after a couple of injections of picibanil, and for a macrocystic lymphangioma, you would aspirate the contents, which is blood here, and inject 1/4. Initially, we started with an equal amount of injection. Now we learned that a much lower dose of 1/4 of volume of the blood aspirated in a macrocystic lymphangioma can actually take care of the lymphangioma, and it settles down very well. Acute bleed, you would have to evacuate and inject bleomycin. And for anterior lymphangiomas, you simply don't have to do anything. This is a microcystic lymphangioma where there is not going to be any aspirate. You simply inject 1/4 of the volume of the tumor as estimated by your CT scan or MRI. Again, an anterior lympangioma, macrocystic, aspirated and injected. Now you have a situation like this where a child has a tumor which is involving the roof of the orbit, and because of the chronicity of this lesion, we already suspect that the child may have eosinophilic granuloma. Here the approach is going to be completely different. You're not going to curate it only because the dura is already involved here and you don't want any risk to this child. So you would go by a safe approach where you would want to do biopsy from the center of the lesion, which is absolutely safe. Make this child wait under anesthesia for about 10-12 minutes, and your pathologist confirms the diagnosis of eosinophilic granuloma. Sometimes they need IHC, that's a different situation. But if they can actually confirm the diagnosis of eosinophilic granuloma, you go ahead and inject Transilone right into the lesion under visualization, and within 3 months you see significant bone remodeling, and within 6 months the bone is completely remodeled without any need for major surgical intervention. So you have an advantage here by having an in-house ophthalmic oncopathologist who would be able to help you diagnose a lesion on the table, and this is exactly a similar situation. Now, incisional biopsy is something most of us don't take very seriously. We would possibly ask our fellows or even junior fellows to do incisional biopsy. But incisional biopsy has a binding on you that you have to make efforts to get the diagnosis. Otherwise, there's no point doing an incisional biopsy. We know that 8 to 20% of orbital biopsies result in non-specific or misleadingly wrong diagnosis, and that is the reason why we have to be very clear when you biopsy it, and you should not have sampling errors. When I look at a tumor like this, I would estimate the epicenter of the lesion. That's the epicenter. So I would do a superficial biopsy, mid-zonal biopsy, deep biopsy, past the epicenter. Or you may want to do a biopsy of this sort where you have the entire epicenter already involved in the biopsy. Why do we need to do that? I'll just show you this case where superficial biopsy showed only fibrosis and inflammation, which would have made you diagnose this case as non-specific orbital inflammation, and you would have perhaps treated this child with steroids with disastrous consequences because he actually has rhabdomyosarcoma. And the superficial fibrosis and inflammation was a reactive process by the body because of a necrotic round cell tumor, which was there. So you have to be very clear when you biopsy children, especially when you think of round cell tumors. This was a bilateral orbital mass with acquired telecanthus. You can see flattening of the nasal bridge as well. We thought it could be vaginous. Superficial biopsy showed inflammation and fibrosis. Deep biopsy was suggestive of vaginous because he had granulomatous inflammation, but there were multinucleate giant cells. So we asked our pathologist to do a special stain, which is GMS stain, and that was very clinching in terms of diagnosis because it was fungal granuloma, where use of steroids would have been disastrous. So orbital biopsy should be a layered approach, superficial, intermediate, and deep, well past the epicenter. And in a given situation where you really need a confirmation of diagnosis, you should ask for a special stain as well. Excisional biopsy is reserved for benign and malignant tumors, which are well circumscribed. Irrespective of what could be the final diagnosis, if the tumor is well circumscribed and it is not related to any of the critical structures in the orbit which may cause functional deficit, you should go ahead with excision. There is no reason to biopsy a well circumscribed orbital mass. You have to excise it. The approaches are many, and we currently favor transconjunctival approaches for tumors which are in the medial, inferior, and lateral orbit. Except those in the superior orbit where you have to go through the levator, we avoid this approach, but rest of the incisions are very, very conservative and accessible. Patients of this sort, dermoid, obviously lymphangioma, you can do a vertical lid split. This could be dealt with by a subro incision for an incisional biopsy. These are some of the lateral orbitotomy incisions. But what is really caught on is the minimal access surgery. These are the transconjunctival approaches here, which could give you access to the medial, inferior, and lateral orbit. We generally go by the transfornical approach rather than transperilimbal approach. This was a child with orbital teratoma, but unfortunately the tumor lesion was on both the sides of the optic nerve. Here we approach by inferior transconjunctival approach with a lateral canthotomy and inferior cantholysis. This is the cystic component which was on the lateral aspect, and that's the optic nerve. Since we do surgery under an operating microscope, you can visualize all the structures. Nothing is left to imagination when you can visualize, and that is the medial or solid component which was medial to the optic nerve, and that was a lesion that was excised. This was a groove through which the optic nerve was traveling, and the child has good results except for the esotropia, which is persisting, which will need some repair. Now, this was a young lady with intraconal orbital mass, which was a cavernous hemangioma. I'll go through this video very quickly. You can see that that's the approach that we are making, lateral canthotomy and inferior cantholysis. In some situations, you can actually avoid lateral canthotomy and inferior cantholysis. Then you go directly to the periosteum. That's about 2 to 3 millimeter below the inferior orbital margin. Then do a periorbital dissection till you reach one of the endpoints, either inferior orbital fissure, the apex of which, or the infraorbital nerve. You don't want to transgress either of these two structures. And then you further dissect the periorbita in the area where the tumor is located, dissect the tumor to about 40 to 70% of its extent, and then use a cryoprobe for a gentle hold on the tumor anteroposterior traction and wriggle the tumor out. And as it comes out, look for the posterior vascular pedicle, which you're supposed to cauterize, and closure becomes very easy. I'll skip all this, just a bit about multimodal treatment. Multimodal treatment is a combination of surgery, radiation, and chemotherapy, which you are supposed to use in a given situation such as rhabdomyosarcoma or adenoid cystic carcinoma. It can really change the prognosis in the management of adenoid cystic carcinoma of the lacrimal gland. When you begin with chemoreduction, reduce the tumor, make it more consolidated, then you do a en-bloc excision, and finally follow it with adjuvant extended field radiation and adjuvant chemotherapy as well, where many of these eyes which were otherwise destined to orbital exentration, or many of these patients who are otherwise destined to systemic metastasis, can be very well salvaged. And even in patients who have a bone lesion like this, where the bone is involved, can have complete remodeling of the bone, as you see here, without any orbitectomy that is required. So in conclusion, I would say that logical approach to orbital tumors, beginning with a good clinico-radiological correlation, a customized plan for a given patient, use of histopathology for confirmation of diagnosis and adjuvant treatment can optimize outcome. Thank you so much. Sorry for exceeding time.
Thank you, Dr. Santosh. That was an excellent overview. As always, you've given a very good presentation. I don't think there's adequate time to deal with everything. And first of all, we'll have to thank you for giving us this hall, because we've always been seen in some corner halls. So that this is a great move. Thank you. And I think we have the last presentation, the case presentation by Dr. Shefali.
Yeah. Good afternoon, everyone. Thank you so much to the scientific committee for this opportunity. I'm going to present a case that I saw and learned during my training with Dr. Santosh sir. And I've termed it as Pithos of Pandora because of what unleashed from the Pithos, that is our orbit, much like the Greek legend. So as we know, orbit is a Pandora's box. It can often present us with clinical cases which can be a clinical and therapeutic dilemma or an absolute clinical surprise. I'm going to present one such case of this 46-year-old gentleman who presented to us with swelling and bulging of his right eye for the period of 1 month, associated with pain, which was gradual, progressive, increasing, both in bulging and pain and redness. And there was no other specific history leading to this in the past that we noted. He was non-spoken, non-alcoholic, and there was no other systemic issues that he actually complained about, and we had asked him, and no other consultation sought, and no history of weight loss specifically, and no family history of cancer or no prior treatment that was taken. 2 months prior to his presentation, he looked like this. Absolutely a normal right eye, as you can see, and he looks absolutely healthy. So on examination, he had an obvious proptosis, which was of 9 millimeters. Bend and Valsalva test was negative. There was no dystopia. It was more of an axial proptosis. As you can see, there was severe solid chemosis, dilated blood vessels, but the cornea was clear. When we saw his ocular motility, it was restricted in all directions of gaze, and pupillary reactions were abnormal. His vision was decreased in the right eye, as you can note here, 6/24 and N18. And on his fundus examination, he had disc edema and choroidal folds. No nodes were palpated, and we also did a nasal examination just to rule out any nasal pathology for sino-orbital tumors, and no obvious nasal pathology was noted. So when we see a case like this clinically, when we open up the Pandora's box, many things we can think about. But when we go as a stepwise approach, we should always categorize them into inflammation, infection, and neoplasm. So I've just put up this slide here just to show what all lesions can simulate such a presentation. And I'm going to come back to it after I have taken you through the radiology of this patient. CT scan showed a heterogeneous intraconal mass, and MRI that we did also corroborated with the finding. It was a well-defined mass lesion, intraconal, heterogeneous, and hyperintense. As you can see, there's a peripheral solid enhancing component that is seen, and the extent is from the orbit to the orbital apex. Our specialist has actually marked the optic nerve, which seems to be displaced. And there is definitely a very gross central area of necrosis or mucoid degeneration that we can see here. This slide I've put up just when we see the radiology, what all can we think about? I have a schwannoma here, a neurocysticercosis, and VLM, or a very aggressive malignancy that we can think about. So coming back to this slide, some lesions we can actually eliminate just by the age in which they present, like RMS or orbital retinoblastoma, some by their history. And we should always come up with a list of differentials that we should keep in mind when we are dealing with something which is not very straightforward that we are dealing with. So in this case, the provisional clinical radiological diagnosis that we kept in mind was maybe a schwannoma because of the onset and the progression of this case, which was kind of acute and leading to too much of inflammation. So we thought maybe it was a neural sheath tumor which underwent a cystic degeneration. And of course, we did keep an aggressive malignancy in mind too. And definitely a biopsy was necessary for diagnosing this case. Well, Pandora was very curious to know what was inside the box, and hence the evil was set out. But we held on to our curiosity because so much of inflammation was going on. We did not jump to orbitotomy or excision biopsy. We decided to treat the inflammation first that was going on and reassess the case. We did start him on steroids, but there was absolutely no resolution that was seen. Second step that we thought about is, since it was well-defined intracoronal lesion, we thought that we'll do a cyst aspiration and see what that aspirate is, so that we kind of get to know what the pathology we are dealing with. And we did a transcutaneous cyst aspiration. A total of 7 milliliters of aspirate was found, which was kind of like a frank blood. We sent it for cytology and microbiology, and the amusing thing was the chemosis or the proptosis did not settle down on table at all. And hence we decided to go ahead with a PET CT scan for the patient. This is the time when the evil actually unleashed in this case, and the cytology came out to be a poorly differentiated neoplasm with certain differentials. And along with that, the PET CT scan was totally clinically surprising. A seemingly healthy looking male had so much of hotspots going on in his body. As you can see, there's a hotspot in the orbit and a very diffuse FDG-avid lesion that is seen in the rectum here. So the working diagnosis according to the PET CT scan was a rectal primary with metastasis. Sigmoidoscopy was done along with the collaboration of our oncologist in the Subspecialty hospital, and it came out to be a round cell infiltration which was possibly malignant, or maybe an adenocarcinoma or a small cell carcinoma. The pathology finally revealed pigment-laden cells, HMB45 positivity, which proved it to be a malignant melanoma. Hence, the final diagnosis was an orbital METS, probably a primary from the rectal malignant melanoma with diffuse metastasis. We did go back and dug into the history, and he did recount 2 episodes of abnormal bowel bladder movement with bleeding per rectum, hence proving it to be a rectal primary because it presented before the orbital lesion, and a diffuse metastasis that we were dealing with. Well, we went ahead with immunotherapy along with our oncologist, and he was started on pembrolizumab, and EBRT with concurrent temozolomide was started. We all know that it is a very advanced and aggressive kind of a disease. It has a poor prognosis, and unfortunately, the patient succumbed to the disease. When we see the survey of orbital tumors done by the Shields group and other studies that have been published, we know that orbital METs are around 3 to 7% of the lesions that we deal with. Melanomas have been documented, but the most common sites of metastasis would be something that we think about is breast, lung, or prostate. Even when we see, this is one of the recent papers which deals with the survey of the orbital METs, which is a good paper that we can read. And when we see the melanoma that metastasizes to the orbit, most of them are either cutaneous or choroidal melanoma, and rarely alimentary tract melanoma or a rectal melanoma has been documented. This is one detailed paper which deals with a similar kind of a presentation, which has been published in IJO. That is the only paper I could find about this kind of a disease. So what makes this case worth a discussion? Well, the rarity of it. Orbital METs itself are not so common. The primary and the secondary location of this case was extremely rare, and anorectal melanomas are itself less than 1% of all anorectal malignancies. The points of contention throughout the treatment and the journey of this case was the age, the seemingly healthy male that we were dealing with, the differentials that we had to keep in mind, and the timing of the biopsy was also a challenge because of so much of inflammation that was going on, and the treatment strategy that we employed for him to help him. And the take-home message would be that orbit is definitely a Pandora's box. We can have very straightforward pathologies or very, very complex and difficult cases that we deal with. But if we go step by step and with caution, we can reach to a diagnosis. And definitely accurate history is a key to solving all these mysteries, and hence we should definitely dig into the history very well. And all these are complex cases which require multidisciplinary approach, and close collaboration with the oncologist and other specialties is definitely needed. These are my references. Thank you so much for your patient listening.
That was a fantastic case, and to be very honest, I'm sure none of us would have even ever thought of it. One. But the biggest conclusion I get is no tumor or no disease nowadays follows any rules or regulations described in the books. So I think we ought to be even more stringent in our evaluation and history, which I think is really, really important, which cannot be overemphasized in this particular case. Excellent presentation and excellent take-home message. Besides the case, I think we all have to now resort to good history taking and good examination, and also coordinating with other subspecialties, which we often miss. Thank you very much.
Thank you, ma'am.
May I request Dr. Siddiq to please conclude with his comments.
Thank you, Dr. Asa. Actually, I'm not an oculoplastic surgeon. I'm a neuro-ophthalmologist. But by sitting here, I saw all the speakers have been delivered the topics very clearly. I think very practical for the ophthalmologists for their daily practice. And I also give the appreciation to the audience that still sits until the end of the session. Thank you. That's all, Dr. Natasha.
Thank you. Seema, hand over to Seema.
Thank you, Dr. Siddiq. Thank you, everyone on the dais here for your valuable time, and to all the speakers for such a very, it's very difficult to cover orbit in a short span, but thanks for all the, wonderful talks and sharing your experiences.
Dr. Seema and Dr. Usha and the people on dais, may I request you to convey the message? When is it so very important to refer a case of proptosis to the specialist and not just sit on it? We can just...
For me, at least I'll stick on to my topic, optic nerve sheath fenestration. See, often neurologists do not know that oculoplastic surgeons do this particular procedure, number one. And they often try all the aspects and then send it to us. This is the reason why there's a high failure in getting back the vision. So I think it's important for us to present in whatever forum possible, even if we have just a handful of audience, keep presenting and keep getting the other specialists involved. That's number one. I think any case of proptosis, I think it's best we educate our ophthalmologists first to refer it to an oculoplasty person before they start intervening.
And Dr. Seema, inflammations, because it is seen by everyone as a general ophthalmologist. When would you, say that it has to be referred to the
inflammation is
specialist?
one disease which is probably the most misdiagnosed and probably most inappropriately treated. Again, here it's important to go on a step-by-step approach, and the crux here is that we need to rule out any other pathology, because we know tumors can mimic an inflammation, infections can mimic an inflammation, and anything, probably any orbital disease can actually present like an inflammation. And we do see a lot of patients where the first line treatment has been steroid even without a proper evaluation and a biopsy. And I think that's the point, again, as Dr. Usha mentioned, even before we go down to the rest of the group of ophthalmologists, even as oculoplastic surgeon, we need to be very careful what are the indications for biopsy before we decide that we need to start the patients on steroid. Because there are cases, Dr. Santosh keeps on talking about those cases where the tumors has been missed because the initial treatment has been with steroids. So that aspect, once taken care of, will definitely make things much more, better.
Thank you. Yeah, and we all agree that orbit is a Pandora's box, and more than eyelid and conjunctival tumors and lesions, which is very evident otherwise for your naked eye, orbit is something which has to be referred if at all there is even a very minimum doubt about the pathology, I think so. Thank you so much, Dr. Seema, for conducting this session well. Thank you, Dr. Usha. Thank you, Dr. Mohammed and Dr. Grover, for having you with us. Thanks a lot.